Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you for joining us for the European Hematology Association conference coverage, clinical clips in newly diagnosed multiple myeloma. My name is Peter Voorhees, and I am a clinical professor in hematology oncology at Atrium Health, Levine Cancer Institute, Wake Forest University School of Medicine. In this clinical clip, I will present key data presented at the 2024 European Hematology Association Annual Congress in Madrid, Spain. So there's a lot of really exciting, data that is being reported out at the EHA meeting this year in newly diagnosed myeloma, and I thought I would focus my attention in that particular space. And I'm going to start off with studies that were done for newly diagnosed patients who are less fit and not intended for an upfront autologous stem cell transplant. And with that, I'd like to discuss the first abstract, which is the phase 3 IMROSE trial that was the subject of a plenary session earlier today. So IMROSE was a randomized phase 3 study that evaluated the safety and efficacy of incorporating the CD38 antibody isatuximab into the bortezomib, lenalidomide, dexamethasone backbone for newly diagnosed myeloma patients who are not felt to be appropriate candidates for autologous stem cell transplant. Patients received 24 weeks of induction therapy with either the 3-drug or the 4-drug regimen, followed by treatment with lenalidomide and dexamethasone or isatuximab, lenalidomide, and dexamethasone until disease progression or the development of unacceptable side effects. And the primary endpoint of the study was progression-free survival. Now, importantly, the addition of isatuximab did, in fact, improve progression-free survival. In fact, the hazard ratio was 0.6, translating into a reduction in the risk of progression or death from any cause of 40% with the addition of isatuximab into the VRD backbone. And the 5-year progression-free survival in the experimental arm was 63.2% versus 43.2% at 5 years for the triplet. Now, as far as the safety is concerned, the addition of isatuximab to the VRD backbone increased the rates of grade 3 and higher neutropenia. But when you account for the length of time that patients were on treatment, this did not translate into an increased risk of grade 3 or higher infections. And the other non-hematologic toxicities are very similar between the two arms. Thus, a very safe and effective quadruplet in transplant ineligible patients. And this is really the first study demonstrating that a quadruplet in a non-transplant setting yields an improvement in progression-free survival. It's important to recognize that the median age in this study was 72, 73 years of age, so one could argue that some of the patients in this trial were transplant eligible. Nonetheless, whether these are transplant ineligible or patients who have deferred an upfront autologous stem cell transplant, it clearly supports the notion that a quadruplet in the absence of an upfront transplant does yield improved progression-free survival with acceptable safety. Now, we know that from the MAIA trial that the addition of the CD38 antibody daratumumab to the lenalidomide and dexamethasone backbone is a very effective treatment strategy for patients with newly diagnosed myeloma who are not transplant eligible. So the question is, when we're thinking about triplets versus quadruplets, what is the added value of the proteasome inhibitor in the quadruplet? In other words, should we really be comparing these quadruplets to VRD, or should we be comparing them to a CD38 antibody plus lenalidomide and dexamethasone? And that's where the benefit trial comes in. So this was a randomized phase 3 study that was conducted by the IFM. And specifically what they did is they took newly diagnosed patients who, again, were not thought to be transplant candidates, and they assigned them to one of two arms. The control arm was the combination of isatuximab with lenalidomide and dexamethasone. The experimental arm was isatuximab with lenalidomide and dexamethasone, with the incorporation of bortezomib. Now, the important thing about this study is that the bortezomib was administered in a real-world fashion. So for registrational studies, bortezomib is oftentimes given twice weekly for the first 2 weeks of a 3-week cycle, and that typically leads to high rates of bortezomib-induced peripheral neuropathy, including high rates of grade 2 and higher bortezomib-induced peripheral neuropathy. So what they did in this particular study is that they gave the bortezomib on day 1, 8, and 15 of a 28-day cycle. For the first 12 cycles, they only gave the bortezomib on day 1 and 15 for cycles 13 through 18, and then the bortezomib was omitted from the regimen. And I'll also point out that the dexamethasone was omitted from the regimen after cycle 12. So the important thing about this particular study is that even though they used less intensive bortezomib dosing, and even though they took out the dexamethasone after 12 cycles of therapy, MRD negativity rates at 18 months, which was the primary endpoint of this trial, were higher with the quadruplet versus the triplet, specifically 53 versus 26%. So essentially a doubling of MRD negativity in this particular trial. Now, median follow-up is relatively short. The progression-free survival curves appear to be diverging, but they're going to need longer follow-up to really assess the impact of the bortezomib on the progression-free as well as the overall survival. But from a safety perspective, it was actually quite good, and the rates of grade 2 and higher peripheral neuropathy were lower than what we would typically see when bortezomib is given in the registrational twice-weekly paradigm. So very interesting results there. Now, in the transplant-ineligible patients, I now want to pivot to CAR T-cell therapy, and specifically I want to talk about the EQUACEL trial. So this is a study that was looking at consolidation therapy with a fully human BCMA CAR T-cell product in patients with newly diagnosed multiple myeloma who were felt not to be candidates for upfront autologous stem cell transplant and specifically had high-risk baseline features. And in this particular study, 100% of the patients had high-risk cytogenetic abnormalities, and 25% of the patients had extramedullary disease. Now, it's a very small sample size, specifically 16 individuals, but not surprisingly, the overall response rate with this therapy in a newly diagnosed patient population, a high-risk one at that, was 100%. With complete responses in 93% of patients. And when you look at minimal residual disease negativity at 10 to the minus 6, 100%. Now, follow-up is relatively short, so we'll have to see, the durability of these responses over time, but this is a absolutely terrific start, for patients with high-risk disease biology. So we certainly look forward, to seeing those data report out over time. So the next thing I want to do is pivot to newly diagnosed patients who are felt to be transplant eligible. And the first abstract that I want to review is the updated data from the phase 3 Cassiopeia trial. So Cassiopeia was a phase 3 study that looked at the addition of daratumumab into the bortezomib thalidomide dexamethasone backbone for newly diagnosed transplant-eligible patients with multiple myeloma. So in the control arm, patients received 4 cycles of VTD induction, followed by a single autologous stem cell transplant, and then 2 cycles of post-transplant VTD consolidation. The experimental arm received the same therapy with the addition of daratumumab into the regimen. Now, the important thing about this particular study is that after patients had received consolidation therapy, there was a second randomization where patients either received daratumumab monotherapy as maintenance once every 8 weeks for a total of 2 years, or they received no maintenance therapy. Now, the primary endpoint of the first randomization, which was achievement of stringent complete response by the end of consolidation therapy, has previously been reported and demonstrated that the rates of stringent complete response in the quadruplet arm were superior relative to the triplet arm. So now, with longer follow-up, we can see that this translates into a median progression-free survival for the triplet group of 52.8 months versus 83.7 months for those patients receiving the quadruplet. So in other words, median progression-free survival, I'm not talking about overall survival, but median progression-free survival for the quadruplet treated patients in this study was approximately 7 years. Now, when you look at overall survival, with long follow-up in this study, you actually start to see an overall survival advantage emerge as well. And specifically, if you look at 72-month overall survival or 6-year overall survival, it was 86.7% for those that received the quadruplet, compared to 77.7% for those who received the triplet. The hazard ratio was 0.55, so you're looking at a 45% reduction in the risk of death of any cause for those patients who received the quadruplet versus the triplet. Now, I want to talk about the second randomization. So when these data were first presented and published, what was very interesting is that the progression-free survival appeared to be very similar whether you got daratumumab in induction and consolidation, in maintenance, or both. So the question that emerged was, if you're getting a CD38 antibody, as part of the initial quadruplet therapy, is there value to adding the CD38 antibody as part of maintenance therapy? Now, when you look at progression-free survival from the second randomization, so from the time of maintenance, at 6 years, it was 57.1% for those that were assigned to daratumumab versus 36.5% for those that were received observation. So there's absolutely no question that daratumumab monotherapy is effective as maintenance therapy after induction, transplant, and post-transplant consolidation in newly diagnosed multiple myeloma patients. But the important thing to recognize is that with long follow-up, progression-free survival was best for those patients who got daratumumab as part of their induction and post-transplant consolidation and as maintenance therapy. That was the arm that did the best out of the four. And when you look at sustained MRD negativity, it was 56.3% of the patients who got daratumumab as part of induction, consolidation, and maintenance therapy, in contrast to 46.3% for those that got daratumumab just as part of induction and consolidation, but not in maintenance therapy. It was 44.1% for those that got the triplet as part of induction and consolidation, followed by daratumumab maintenance. And those that got no daratumumab, either as part of induction and consolidation and no daratumumab maintenance therapy, they had the lowest rates of sustained MRD negativity at 24.7%. Now, one of the arguments that people oftentimes make when you're adding all of your best assets as part of upfront therapy is, what am I going to do, when the disease relapses? And have I burned bridges by using my CD38 antibody as part of the initial treatment? So they looked at that, and in fact, those patients that had been assigned to the triplet arm of the study were more likely to get daratumumab-based or isatuximab-based therapy in first relapse. However, if you look at progression-free survival too, so that is measuring from the time of the first randomization in the trial to the time of their progression on their second line of therapy, that still was in favor of the quadruplet, suggesting that you are not, in fact, burning bridges when you add daratumumab as part of the upfront therapy. So now I want to pivot to the Perseus trial. So Perseus was the randomized phase 3 study looking at the addition of daratumumab into the bortezomib, lenalidomide, dexamethasone backbone for patients with newly diagnosed multiple myeloma who are again considered eligible for autologous stem cell transplant. We know now that lenalidomide is the preferred IMiD in the upfront setting. We don't use thalidomide as much anymore. So Perseus was designed similar to Cassiopeia with a couple of important differences. So patients who are assigned to the control arm receive 4 cycles of VRD induction therapy, a single transplant, and then 2 cycles of post-transplant VRD consolidation therapy, followed by lenalidomide maintenance therapy. The patients in the experimental arm got the very same backbone, but daratumumab was added to the induction and the post-transplant consolidation, and it was applied to the first 2 years at least of maintenance therapy. Now, for those patients that were in a sustained MRD negative complete response, they could actually omit the daratumumab from their maintenance therapy at the 2-year mark. So this was an MRD adapted maintenance in that arm of the trial. Now, the primary endpoint of the study was progression-free survival. Now, importantly, when you look at 4-year progression-free survival, it was 84.3% for those who received the quadruplet, and it was 67.7% for those that received the triplet. This translated into a hazard ratio of 0.42. In other words, a 58% reduction in the risk of disease progression or death when daratumumab is added into induction, consolidation, and lenalidomide-based maintenance therapy. Now, when you look at sustained MRD negativity, it was 64.8% for those in the quadruplet arm versus 29.7% in the triplet arm. And the subject of this particular presentation, which was, evolution of MRD negativity over the course of the trial, importantly, that what they saw is that the rates of MRD negativity at 10 to the minus 6 level sensitivity gradually increased over time and always favored the daratumumab arm, such that best MRD negativity at 10 to the minus 6 was 64% of patients in the quadruplet arm compared to 31% of patients in the control arm, really supporting quadruplets as the new standard of care in transplant-eligible patients with newly diagnosed multiple myeloma. Now, going back to the Cassiopeia data, again, the question is, for Perseus, these impressive results with regards to sustained MRD negativity and progression-free survival, how much of that benefit is derived from the daratumumab that's given as part of the induction post-transplant consolidation, and how much of that is due to the incorporation of the daratumumab into the maintenance therapy. And, I don't think it's possible to really, state the relative impact of the daratumumab in those two spaces. But, again, based on the long-term follow-up of the Cassiopeia study and the fact that there was a higher rate of MRD positive to negative conversion in the experimental arm of Perseus, that would suggest that the doublet maintenance therapy is probably the preferred way to go. Now, there was a similar study that was conducted, specifically the GMM-GHD7 study, that was the subject of a presentation at EHA this year as well. So GMM-GHD7 is a randomized phase 3 study, which is similar in design to Perseus, with one important difference. So this is a study that was, again, looking at patients with newly diagnosed multiple myeloma who were considered transplant eligible, and it evaluated the efficacy and safety of adding isatuximab to the VRD backbone. So the way that this study was done, patients were randomized to either VRD for 18 weeks or ISA-VRD for 18 weeks, followed by either a single or a tandem transplant. Importantly, in this study, like the Cassiopeia trial, there was a second randomization at the time of maintenance to either lenalidomide alone or isatuximab plus lenalidomide. Now, we've already seen these data before. The first primary endpoint of the study was achievement of MRD negativity at the end of induction therapy, and what they previously had presented and published is that the rates of MRD negativity in the quadruplet arm were higher relative to the triplet arm, and that was highly statistically significant. The EHA presentation looked at evolution of MRD negativity after receipt of autologous stem cell transplantation. And what they showed in this particular study is that the rates of MRD negativity after recovery from stem cell transplant was 66.2% for those that received the quadruplet versus 47.7% for those that received the triplet. So, we're seeing this deepening of response after autologous stem cell transplant, but still, the quadruplet induction therapy clearly showing a greater depth of response. So we very much look forward to seeing, longer follow-up, longitudinal outcomes of progression-free and overall survival And perhaps just as importantly, or more importantly, the results of this second randomization are going to be key. In other words, if you get a CD38-based quadruplet in a transplant-eligible patient population, is there value to adding the CD38 antibody into the maintenance therapy? And this is the study that will definitively answer that question. Now, the last abstract I'm going to discuss is another CAR T-cell study, specifically the FAST CAR T-cell study that was presented. This was a trial in newly diagnosed myeloma patients who were considered transplant eligible. And just like the other CAR T-cell study, the EQUACEL study that I mentioned previously, this was a study that was conducted specifically for patients who have high-risk disease biology. And in this particular study, 52% of patients had high-risk cytogenetics, and quite remarkably, 58% of the patients had extramedullary multiple myeloma. Now, the way that this study was designed, patients received 2 cycles of bortezomib, lenalidomide, and dexamethasone induction, followed by CAR T-cell therapy with either 1, 2, or 3 times 10 to the 6 CAR T-cells per kilogram, and then patients went on to lenalidomide maintenance therapy. Now, importantly, in this particular study, the overall response rate was 100%, and the rates of MRD negativity and stringent complete response was a remarkable 95%. Perhaps, encouragingly and surprisingly, the rates of CRS were not that high at 28%, and all of them were grade 1 and 2 in severity. And also remarkably, there were no episodes of ICANS in this particular study, and at least to date, they haven't seen some of the other neurotoxicities that have been reported with other BCMA-based CAR T-cell therapies. So really quite a remarkable result. Granted, a very small number of patients, but it'll be very interesting to see, how this data matures with longer median follow-up. And, really just absolutely remarkable, whether you're looking at patients who are intended for an upfront transplant or not, the outcomes of patients with newly diagnosed multiple myeloma are vastly improving. And I think this year's European Hematology Association meeting really emphasizes that point. It's really a new day for patients with myeloma, which is really exciting. Thank you again for joining us for European Hematology Association conference coverage, clinical clips and newly diagnosed multiple myeloma. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access downloadable slides, as well as other topic segments and case scenarios.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.